Let's go over the warm-up. First question, which type of hypersensitivity is responsible for each of the following clinical scenarios? Post-streptococcal glomerulonephritis is a type 3 hypersensitivity. Rheumatic fever is type 2 hypersensitivity. Polyarteritis nodosa is type 3. Serum sickness is type 3. And then contact dermatitis is a classic type 4 hypersensitivity. Last question, what are the differences between essential tremor, resting tremor, and intention tremor? So essential tremor is a tremor that occurs both with movement and at rest. There's often a family history of tremor in these patients. Intention tremor is associated with cerebellar damage, and this tremor appears only with voluntary movements. So when you intend to move, the tremor kicks in, so it's called an intention tremor. And then resting tremor is associated with Parkinson's disease, and this tremor occurs at rest, but then it disappears with voluntary movement. Now let's move on to the lecture.
Hello everyone and welcome to our step 1 video on the lower extremity. To all of you that nervously bounce your legs up and down while studying, please stop. You're freaking the rest of us out. Thanks bunches. Okay guys, so this one is pretty anatomy heavy again. We're talking about the lower extremity. And in that last video we hit the upper extremity, so now we're moving to the lowers. Now we're looking at the lower extremity nerves and then the muscles that they innervate, and also pay special attention to the injuries and the sensory and motor deficits. All right, so let's talk about the femoral nerve first. So it's going to innervate the psoas and the iliacus. Now together they make the iliopsoas. You're going to hear that probably more often. Now it also innervates the pectineus and the sartorius. So those are your 3 hip flexors. So the iliopsoas, the pectineus, and the sartorius. Now the femoral nerve also innervates the knee extensors. So these would be the quadricep muscles. So that includes the vastus lateralis, intermedius, and medialis, and then also the rectus femoris. So that's what your femoral nerve is going to innervate. So let's quickly review the anatomy again. So first is the femoral nerve. Here you see the psoas muscle. Here is the iliacus, and then together they both make the iliopsoas. Here is the pectineus and the sartorius, that really long muscle going across your leg. And then the vastus lateralis, the rectus femoris, and then the vastus medialis. All right, so that's what your femoral nerve is going to innervate overall. So one way to remember this is that you need the femoral to kick a football. So femoral and football, F and F, remember that. So to kick that ball, you have to flex the hip, you have to extend the knee. So what about sensation? Well, the femoral nerve is responsible for cutaneous sensation along the anterior thigh and the medial lower leg. So how does one injure the femoral nerve? Well, the femoral nerve has the potential of being injured after a pelvic fracture. So after injury to the femoral nerve, patients will have difficulty with that thigh flexion and leg extension, so they can't kick a ball. And then patients would also have that decreased sensation on the anterior thigh and the medial leg. So likely after a pelvic fracture, you won't be able to test strength very well because they'll have significant pain and weakness due to that fracture. But you might get a better idea if the femoral nerve is damaged by testing the sensation of that anterior thigh, or again, that medial lower leg. So now let's move on to the obturator nerve. So what about that one? So your obturator nerve innervates the adductors of your hip. So this includes your adductor magnus, longus, and brevis. And then your gracilis is the exception. It's a knee flexor. So it's going to innervate one knee flexor as well, but also I want you really to connect obturator nerve with the thigh adductors. So one way to work out the hip adductors is to get on that horrible machine at the gym where you kind of spread your legs apart and then you show off to everyone you're growing, and then you kind of squeeze them together. So one memory tool is that working out your obturator is awkward. So obturator and awkward, remember those two things. So what about sensation? Well, the obturator is going to provide sensation to the medial thigh. That's kind of where that machine is touching you as well. It's another way to remember that. So how do you injure the obturator nerve? Well, an anterior hip dislocation can lead to this, and the patient would be left with decreased thigh adduction, decreased sensation on the medial thigh as well. So remember, anterior hip dislocation. Let's move on to the superior gluteal nerve. So the superior gluteal nerve, it's going to innervate the tensor fascia lata, the gluteus medius, and the gluteus minimus. And these are involved with hip abduction and medial rotation of the thigh. So hip abduction, medial rotation of the thigh, remember that. Now the superior gluteal nerve does not supply any sensation to the leg, so that's easy. And this nerve tends to be injured with posterior dislocation of the hip. And it's also famously injured in polio as well. An injury to that superior gluteal nerve gives rise to a characteristic type of gait called that Trendelenburg gait. Now, normally, whenever a person takes a step, the gluteus medius contracts in order to keep the pelvis from tilting downward towards the leg that was raised. If you lose the ability to contract that muscle, then you will see that tilt of the pelvis to the contralateral side. So the contralateral hip drops when standing on the leg ipsilateral to the side of the lesion. Now, the Trendelenburg gait is actually a compensation gait where the patient has to kind of lean towards the affected side to attempt to keep the pelvis level. All right, moving on to the inferior gluteal nerve. So this is going to innervate the gluteus maximus, and that muscle is involved with hip extension and lateral rotation of the thigh. Now, injury to this nerve is actually pretty rare. It could happen with a posterior hip dislocation. Sometimes it can occur with a posterior approach to the hip during hip replacement surgery as well. Now, with this injury, a patient would have a hard time getting up from a seated position or climbing stairs or really even just walking. Next is the sciatic nerve. The sciatic nerve begins in the lower back and it runs through the buttock and down the leg. Now, at some point between the pelvis and the popliteal fossa, it's going to branch into the tibial nerve, which travels down the posterior compartment of the leg, and it branches into the common fibular nerve, which travels down the anterior and lateral compartment of the leg. Now, the tibial branch innervates the biceps femoris, your semitendinosus muscle, and the semimembranosus muscle. And it's also your adductor magnus as well. Now, these are involved with hip extension and knee flexion. Hip extension, knee flexion. And those first three are essentially your hamstring muscles. Also note that the adductor magnus muscle is innervated by both the obturator nerve and that tibial nerve, also known as the tibial branch of the sciatic nerve. So the sciatic is going to supply sensation to the posterior aspect of the thigh and the gluteal regions as well as the entire lower leg except for the medial side. Now, injury or compression of the sciatic nerve is actually very, very common. Intervertebral disc herniation, spinal stenosis, spondylolisthesis can all cause compression of the sciatic nerve, which leads to pain in the lower back, the buttock region, and then pain is going to travel down the leg. Now, remember, the famous straight leg test where you're having people lay down, lift your leg up straight, is often very helpful in the diagnosis with this one. All right, so now let's move on to the tibial nerve. We're actually moving further down the leg. So the tibial nerve innervates your calf muscles, your gastrocnemius, the soleus, and the plantaris. So those are involved with plantar flexion. So your popliteus is a muscle that unlocks the knee when your knee is locked in extension. The flexor hallucis longus and the flexor digitorum longus are involved in toe flexion. Your tibialis posterior is involved with inversion of the foot. So lots of different actions there. Now, the tibial nerve will contribute to the formation of the sural nerve. The tibial nerve will then branch into the foot, into the medial plantar nerve and the lateral plantar nerve. Sensation of the tibial nerve will include the sole of the foot, important one there. Now, the sural nerve, one of the branches there, will provide sensation to the back of the calf. So when might you injure the tibial nerve? Well, with knee trauma, you might injure the tibial nerve. It's running right behind the knee, so it would be susceptible to an injury there. Look for loss of sensation again on the sole of the foot. Let's move on to the common fibular nerve. The common fibular nerve is also known as the common peroneal nerve. You might actually hear peroneal a little bit more often. So the common fibular nerve innervates the peroneus longus, the peroneus brevis, and the short head of the biceps femoris muscle. So this nerve is going to give rise to the lateral sural cutaneous nerve and the superficial fibular nerve. Sensation is the lateral lower leg and the top of the foot this time. Now, damage to this nerve typically results in a foot drop. So you lose dorsiflexion. The patients can kind of drag their foot along when they walk. Patients can get what's called a peroneal neuropathy, where patients will develop problems from chronic compression, like prolonged bed rest, or even just from habitual leg crossing. This can happen as well. It's also commonly injured with a fracture of the neck of the fibula. Next, we have the deep peroneal nerve, also referred to as the deep fibular nerve. So the deep peroneal nerve innervates the peroneus tertius, which is involved with foot eversion. It also innervates the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus. So all three of those are going to be involved with dorsiflexion again of the foot. Now, injury to this nerve can occur with a traumatic injury to the lateral knee, and again will result in a foot drop. Now, just like, again, like the common peroneal or the common fibular nerve with that foot drop. So those two you can kind of put together. Okay, so I know this material is hard to memorize. Let's review it again with a Lewis notes.
All right, everybody, we're going to go through our lower extremity nerves now. First, we're going to go through our green section here. That's going to be the types of injury that's going to cause injury to these nerves. And then the blues are going to be the type of manifestations you're going to see with that nerve being injured. So first one here, we have anterior hip dislocation. That's going to go with your obturator nerve there. Disc herniation, that one's easy. That one goes with sciatic. I always think of an old guy going, my sciatica, and that always makes me think of back pain. Pelvic fracture is going to be over here with the femoral. And remember, write these along with me. It'll help you remember that stuff. Posterior hip dislocations. We have two of these in a row, and luckily they kind of go into the same place. The way I remember that is that gluteals in the butt and posterior of the hip is kind of the butt area. So posterior gluteal, that's kind of how I remember that. Knee injury, just a general knee injury, that's how I remember the tibial. But then a lateral knee injury is going to go over here with the deep peroneal. So that goes there. So now let's talk about the type of manifestations we're going to see here. So first we have a sensation of the lower leg. Now this excludes the medial side. I didn't put that on there because I ran out of room. But that's going to be with your sciatic nerve here. Foot drop, when you have a foot drop, you're going to be harming your deep peroneal nerve here. Trendelenburg gait, that's going to be that funny gait where you're dropping your contralateral hip. That's going to be your superior gluteal there. Plantar flexion is going to be over here with your tibial nerve. Hip extension, this one's a little bit non-specific, but when I think of hip extension, I think of my inferior gluteal. There is some of that with superior gluteal as well. Thigh adduction, so that's the adduction, that's going to be over here with your obturator nerve. We're going to pull that there. Thigh flexion is going to be right above that, so femoral and obturator work side by side. Sensation of the anterior thigh. So sensation of the anterior thigh is going to be over here with your femoral. So I think when you're doing your thigh flexion, you're also looking at the front of your leg. So that's anterior thigh where you're going to see sensation. Then sensation of the medial thigh on the inside kind of goes along with that adduction as well. That's how I remember that. All right, so that is a little bit complicated, but write these yourself and I think you'll get them down.
All right, so now we're moving on. Let's talk about the lower extremity dermatomes, and this is worth knowing again. So first you have T10 dermatome. That's going to start about your belly button. And now underneath that you have the T11 and T12. And then you really just label them going down. L1, L2, L3, L4, L5, and then your S1 on your fifth toe, and then S2, S3 innervate your genitalia as well. Now on the posterior aspect, starting at your rectum, the rectum is going to start at S5, and then coming off of that you have S4, S3, S2, S1 going down the back of your leg. And then you have the L5, L4, L3, L2, L1, and then to T12 again. So be aware of those. Those are a bit difficult sometimes, but again, you might just need to stare at those a bit to memorize them. All right, so now let's move on to the arteries of the leg. Again, more anatomy. So starting at the top, you have the aorta, and then your aorta is going to bifurcate, and you have the common iliac artery. And then your common iliac bifurcates into the internal iliac and the external iliac. The external iliac gives rise to the deep femoral or femoral, and then the femoral artery. And then the femoral artery goes behind the knee and gives rise to the popliteal artery and the posterior tibial artery, which is the artery of the posterior compartment. And then on the anterior aspect of the leg, you have the anterior tibial artery, which is the artery of the anterior compartment. Now coming off the anterior tibial artery is the dorsalis pedis. So this is the artery that you might try to palpate to determine if lower extremity pulses are strong. And then on the back of the leg, the posterior tibial can give rise to the fibular artery, also known as the peroneal artery. Again, this is just memorization, but overall, not that tough. All right, guys, so that's it for the video part. It's time for the end of session quiz. Try to answer those questions first, and then we'll go through them together. First question, which nerve would most likely be damaged with the following injuries? So first we have a pelvic fracture. Think about your femoral nerve. Next we have the anterior hip dislocation. Think of obturator nerve. Next we have posterior hip dislocation. That's going to be the superior and inferior gluteal nerves. Next we have vertebral disc herniation. That's going to be sciatic nerve. Knee injury, think globally as a tibial nerve. Habitual crossing of the legs, common fibular or common perineal nerve. Next, which nerve is responsible for the following functions? So first we have hip flexion and knee extension. So remember that's your femoral, it's kicking a football. Sensation to the medial thigh. Think of obturator and that terrible machine you got to use. Helps to prevent Trendelenburg gait. Think of the superior gluteal nerve. Sensation of lower leg, except for the medial aspect, think of sciatic. Sensation of the sole of the foot, think of the tibial. Dorsiflexion of the foot, think of the common and the deep perineal / fibular nerve. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.